Good morning, everybody. I would like to thank Dr. Tuhin Chaudhary for making me part of this very important instruction course on limbal stem cell deficiency and management. I will be dealing with the preoperative evaluation of patient selection for simple limbal epithelial transplantation. We are all aware of the stem cell properties, and they have like undifferentiated proliferating cells and present in the self-renewal tissues, and they have long-lived, long cycle time, and they have capacity to divide asymmetrically. Some of the historical points: in 1971, limbal stem cell resides in palisades of Vogt. This was discovered. In 1983, they proposed the hypothesis of niche hypothesis, which is very important, and this is basically the basic of all the limbal stem cell deficiency disorders and its management. And then in 1986, the limbal epithelial was deficient in expression of K3. 2005, Du et al. Reported the presence of limbal epithelial crypts and proposed that they also harbor the limbal stem cells. And this hypothesis XYZ was introduced, and this explains the ocular surface homeostasis basically. One term for those who are newer, I would like to introduce is conjunctival transdifferentiation of the ocular surface. Now, this term was introduced with the concept that after chemical injury, if you make the ocular surface avascular, the conjunctival epithelial cells, they transform into the corneal epithelial cells. And later on, it was proved that it's not true, and then this hypothesis was discarded. Limbal niche is the most important structure because this harbors the limbal stem cells, and this also provides a microenvironment which is essential for the survival of the limbal epithelial cells. And the management strategies also, they are based on this limbal stem cell niche that you have to take care of, and you have to transplant limbal niche if you want to transplant a limbal epithelial cell for longer periods. Coming to the etiology, we have two etiology groups. One is the acquired one, and in acquired we have immune disorders, Stevens-Johnson syndrome, toxic epidermal necrosis, atopic, mucous membrane pemphigoid, and chronic graft versus host disease. Now, this will be taken, I think, by Dr. Swapnil Walekar in later. Of the non-immune related conditions, we have several conditions, but the most important one which we all deal is, and which is threatening, is chemical or the thermal burns basically. And this is one of the most devastating one. And in ophthalmic literature, it used to say that if after central artery occlusion, if there is any other emergency next to it, it's the chemical or the thermal injury, because you need urgent management in the form of lavage so that you decrease the contact time of the damaging agent. Now, this group of the disorders, congenital one, we have several disorders in this group, like congenital aniridia, xeroderma pigmentosa, dyskeratosis. But I think most of the times we have, most important one is the AAK. And this is rare, but when we meet, we have to treat this condition. That is congenital aniridia. Iatrogenic stem cell deficiency is an important group, and we all treat our patients, and we should make all efforts to avoid iatrogenic deficiency. We can have it following contact lens wear, we can have following mitomycin C, and limbal stem cell deficiency after glaucoma surgery, or any multiple surgeries if we have done again in the limbus area, again we can develop this kind of problem. The diagnosis of limbal stem cell deficiency is basically clinical, and in milder cases you can have mild epithelial stripping, persistent or late fluorescence staining of the cornea. recurrent epithelial defects, persistent epithelial defects, vertex keratopathy, epithelial thinning, all these subtle changes in the ocular surface and the cornea, they indicate that we may be having the limbal stem cell deficiency, and we have to specially look for these signs to detect early limbal stem cell deficiency or mild. The moderate or severe severe limbal stem cell deficiency is obvious, and we have the pictures on the other side. We can have pannus, which is progressing, conjunctivalization, corneal vascularization, corneal opacity, symblepharon, pseudotrigium, pyogenic granulomas, or eyelid abnormalities. So that all these are abnormalities, but to find out the subtle changes in the cornea which are suggestive of limbal stem cell deficiency, we should also look carefully limbus, and especially the limbal vessels. They say that like foveal avascular zone, you should give importance to the limbal vascular arcade. And if there are changes in that area, this means that there may be some chemical insult. And this is especially important in unilateral chemical injuries when you are going to take some limbal conjunctival tissue for either Slet or for limbal conjunctival autotransplant. So this is important to make sure that the other eye is perfectly normal. It's not has got any insult. Coming to the investigative tools which can be used to detect limbal stem cell deficiency, impression cytology is one of the most simple one, and it can be done with the help of expert pathologists. Impression cytology shows conjunctivalization of the cornea, and if your smear, which is obtained after impression cytology, shows that there are no cells, or mostly the cells which we are seeing are the corneal epithelial cells, this means that it's sure that we are not having limbal stem cell deficiency. On the other hand, if your conjunctival impression cytology shows conjunctival epithelial cells, or mixture of both corneal and conjunctival epithelial cells, this means that the limbal stem cell deficiency is there. Another way of confirming it is histopathology, which we always do after excising the tissue, conjunctivalization of the corneal or conjunctival epithelium, presence of goblet cells, neovascularization, disruption of basement membrane, and inflammatory cell infiltrate. All these are evidences which suggest that the limbal stem cell deficiency is there. Immunohistochemical studies can also be done, and absence of cytokeratin CK3 also indicate the limbal stem cell deficiency. Some of the imaging techniques like confocal microscopy can be used to detect limbal stem cell deficiency. When we do confocal microscopy, there may be absence of palisades of Vogt. Basal cell with distinct nuclei and indistinct borders is another indication. Metaplastic wing cells, basal epithelial cells, and then decreased basal cell density, decreased subbasal nerve density, and in late stages, the normal epithelium is replaced by the vascular fibrotic tissue. These are the various, these are the pictures at the various stages of limbal stem cell deficiency, and at the various areas, like on the cornea, wing layer, basal layer, and subbasal nerves. You can see that as the disease progresses, the basal nerves, they are decreased, and finally they are absent. And the other picture shows the wing cell layer and basal cell layer in the limbal area. So in the limbal area, the crypts are like in the normal, it's very clearly visible, but once the limbal cell deficiency, the crypts are not visible at all. Going to the anterior segment optical coherence tomography, this is a basically very rapid and non-contact technique, and this is not dependent upon the operator, whereas for confocal microscopy, you need a very expert person who has experience of doing confocal microscopy. This provides instantaneous output and has shown good histopathological correlation. And diagnosis is basically by the epithelial thickness, visualizing palisades and quantifying the stem cells. So you can see A picture is basically the normal one, and in B picture, again, we are seeing the palisades of Vogt. Whereas in D picture, you can see that there is a fluorescent stained and fluorescent pooling area at the limbus. So this area, when we have examined on OCT, This shows that there is a thinning in that area. And again, in the limbal area, in picture F, we are seeing that the limbus is thinned. This is the area where there was pooling. So anti-segment OCT can also be helpful in supplementing the clinical diagnosis. Coming to the anterior segment optical coherence tomography and angiography in assessing limbal ischemia, this has been done by Dr. Sain and other authors, and this is very important. In fact, Professor V.S. Nirankari also has done anterior segment fluorescein angiography of the cornea, and he has treated corneal vessels with various techniques, submitted his thesis for American Academy. So when we are doing CT angio, and we can see the hairpin loops which are visible. So you can see the yellow arrowheads where you can see the hairpin loop vessels, which are normal ones. And again, you can see the Y-shaped pink arrowheads here and green arrowheads. Again, these are vessels which are normal ones. Whereas if there is a limbal vessels which are damaged, ischemic zones, they are shown in the lower picture with the blue heads basically. This picture is basically in acute chemical injury, but the same can be utilized to detect the limbal stem cell deficiency at a later stages of the chemical injuries. Once we have examined the corneal patient for limbal stem cell deficiency, we need to grade the disease. So we have different grading system, but this one is one which can be used conveniently. Now this patient I want to show, because this patient we treated when there was no concept of amniotic membrane limbal stem cells way back in 1977 or 8. So you can see that this patient had bilateral severe chemical injury, and he has chemical injury over the body also. He was admitted in plastic surgery, and I used to take care of this patient regularly. So one eye, he developed, right eye he developed endophthalmitis because of the periocular infection. The other eye, we were contemplating to save this eye. And in this eye, we have a scleral ulceration, limbal ulceration, and then corneal ulceration. At that time, the concept of tenoplasty and glued-on contact lens was there. So we treated him with that. In fact, in this patient, we directly applied the glue on the limbus, cyanoacrylate glue on the limbus, and then glued-on contact lens. And we could tide over this area, and we could save this eye. And later on, this patient saw 636, and we published it in Cornea. Acute chemical injury needs a very efficient management, and if you treat the patient efficiently in acute stage, we are going to get less severe limbal stem cell deficiency, or limbal stem cell deficiency may not appear at all. I must say here that the extent of limbal ischemia determines the area, extent of limbal stem cell deficiency also. So this area is very important because the prevention is always better than cure. In severe chemical eye injuries, there is a multi-stage treatment which is required. All these corneal issues should be solved before we take the patient for definitive surgery, like limbal stem cell transplants, of which various techniques my colleagues will be dealing with. One thing I would like to emphasize, that if you have a limbal stem cell deficiency, which is very early, and this is because of the chronic ocular surface inflammatory disease like VKC. If we treat the inflammation, the limbal stem cell deficiency in early stage in these cases is reversible. This is very important, and we should treat these patients. In fact, otherwise also, whenever we have treating the this area, we need to make the ocular surface as far as normal, so that the microenvironment is very good, and the limbal stem cell transplant we are going to transplant, they survive here for longer periods. AMT is the one which can be used in the acute stage as well as later stages. We should not jump onto the limbal stem cell transplant directly. As far as possible, we should rehabilitate with the amniotic membrane. Then simulacron, ocular adnexa, all these problems should be taken care of before taking patient for definitive surgery. We need to take care of the glaucoma also. Sometimes we are treating and we are not looking for glaucoma. We may lose the patient's sight because of glaucoma. This is one area which we used to do initially, like limbal conjunctival auto transplants. In this patient with the severe chemical injury, severe limbal stem cell deficiency, we have done this limbal conjunctival auto transplant. This is known with the various names, even the conjunctival limbal autograft, CLAU. So it's very useful for unilateral. We had to take larger tissue from superior and inferior limbus of the normal eye. But one thing is sure that we should not consider penetrating keratoplasty without limbal stem cell deficiency. Again, if you have a localized disease, we can combine the two. You can always go for conjunctival limbal transplant along with amniotic membrane. This patient I operated long time back. First, we treated the limbal stem cell deficiency. You can see the area. There is a transition area where you can see the conjunctival limbal auto transplant, and we did penetrating graft. Patient did very well, and in fact, she came for 10 years for follow-up. After that, I have not seen her. PKP without limbal stem cell deficiency should not be done at all. I like to tell the story of this patient, 42 years old male, bilateral severe limbal stem cell deficiency, and we advise the limbal stem cell deficiency treatment, but patient went for PKP at other center. In addition to that, this is the one area which is going to be dealt by my colleagues. This is one patient where we have done PKP following Slet, and cultured limbal stem cell transplant is a good option, but again, this is very costly and doesn't provide the niche which is very essential. So that is the reason the simple limbal stem cell transplant, which is very simple and convenient to master, and we are talking about the simple limbal epithelial transplant in this eye. I have participated in the pilot project, and we had done 10 to 12 cases of this conjunctival cultivated limbal stem cell transplants. In the end, I would like to say that early and efficient treatment of acute chemical injury may prevent or reduce the severity of limbal stem cell deficiency. Despite various advancements, new imaging techniques and diagnostics of limbal stem cell deficiency remains clinical. Patients with limbal stem cell deficiency due to niche dysfunction and underlying inflammation may reverse with the treatment and control of inflammation. Eyelid adnexa anomalies should be treated before contemplating limbal stem cell treatment. Ocular surface rehabilitation is important to improve the stromal microenvironment, which is necessary for the limbal stem cell survival and should be performed before limbal stem cell transplant. Thank you very much for patient hearing.
Thank you, Dr.